Very loud in the room. Welcome to everybody who's online, trickling in. So welcome and welcome to a lot of our students for the beginning of the academic year. So at the beginning of the year, we tend to have a talk about what is global, and as a university, we need to be thinking about what is our role in the world. Education is worldwide, right? So you think about that scope. So it's great to start at the beginning of the year to think about not just, do we learn and teach the basics of medicine and surgery, but do we think about our role within the context of the world? So my name is Sudha Jayaraman. I'm the director of our Center for Global Surgery, which is in the U.S. the oldest center to think about surgery. I have to unmute.
Okay, is that good? How about this? All right, no feedback. God, so many years of technology struggles. Anyway, so as I was mentioning, Center for Global Surgery, and our center, established now 13 years ago, was the first in the U.S. to really be formally taking the role of surgery as a global issue to heart. So this is one of the first institutions to think about surgery in the context of surgery worldwide as an important component to something that we should be thinking about. And I'll tell you a little bit more about that. Before we get started, I would love to do some quick introductions because we do have some visiting guests who have traveled a long distance to come to the University of Utah, and I would love to honor them and ask them to introduce themselves. Would you like to start, Dr. Plowing? Would you say your hospital name as well?
Okay. So it's the Colorado Teaching Hospital. It's the oldest and probably the largest
Wonderful.
in the country. Third largest largest in West Africa and the third largest in the African country.
Wonderful. Thank you very much.
So my name is Aaron Malati Ayabami. I'm a plastic surgeon. I work with Granville Medical Group. I'm the CEO, the Chief Operating Officer, apart from being plastic surgeon. I've been a plastic surgeon for 11 years now. So, and I love being here. I've had a great time learning also, because learning doesn't stop. You need to go to
That's right. That's right.
Thank you.
And what institute?
Nigeria.
In
so
Nigeria?
There are 3 different locations. In Lagos and Abuja. So
Wonderful.
in Lagos, we have 2 sides. We have the mainland, then we have across the sea, which we call highland. So we have some population settled, just like you have the New York.
Yeah.
So
yeah.
we have something like that in Lagos also. So having Abuja, Abuja is the capital city of Nigeria.
Yeah.
So about 5 million population for Abuja. For Lagos, 22 million people.
Yeah. And the country is about 300 million people, which is, and the US is about 300 million, and Ghana is about 30 million, 35. Okay.
My name is I'm Peterson. I'm also a plastic surgeon. I'm also in Colorado Teaching Hospital. And I'm a very nice.
You're welcome.
Papa Fifi Hansen. I'm also a plastic surgeon.
Yeah.
Class.
Yeah, and the former Hand Fellow, so that's also useful. Good to know. Yeah.
My name is Mamadou Lassana Foba. I'm come from Senegal. I'm a plastic surgeon in University of Cheikh Anta Diop, and the hospital is named Fan University. in the capital, in the city.
You're welcome.
I'm happy to be here now.
Dr. Rockwell, or any of this, would the students like to introduce themselves too? Dr. Rockwell, would you like to introduce yourself?
Brad Rockwell, I'm plastic surgery here at the University of Utah, and I've been very fortunate to host the gentleman that you just heard introduce. But it's great. We've had a great week of plastic surgery learning.
Fantastic. Would you all like to introduce yourselves? Just say where you're from and what year you are.
Yeah, I'm Katie. I'm an MS1. I'm originally from Idaho.
Wonderful.
I'm Ben. I'm a first-year medical student in Oregon.
Utah.
I'm a first-year med student from California. I'm Allie, also a first-year med student, and I'm from Salt Lake. I'm Rochelle. I'm a first-year med student from Salt Lake, but I'm interested in plastic surgery, so this is really exciting. I want to get also a first-year student from Idaho.
Wonderful. And Anna, Liz, or our CGS staff, I'll have them also, I'll introduce them as well. Okay, great. So thank you all for being here. So how do I advance on this? Why is this so difficult?
I know, we're getting it quicker.
Okay, all right. Okay, all right. So let me ask you a simple question. Everybody knows the answer to this question. What is global health? Well, what's the first thing you think of? What are the things you think of? Well, I think of this, right? Vaccines and the COVID pandemic, which is a major global issue. We often think about the big three. We also think about water and sanitation. But how often do we think about surgery as a major component of global health? We don't typically. It seems kind of awkward to kind of combine the two things. And you say, well, these are two totally different things. They can't be combined. They shouldn't be combined. And that's part of the reason why we're talking about global surgery today, is the story of why surgery is actually a part of systems of care worldwide. Just because you're in Malaysia doesn't mean that you're going to not need a surgeon for appendicitis. Just because you're in Idaho, which is our fairly rural, some of our rural states, doesn't mean that you're not going to need a surgeon for appendicitis. So these needs and systems are necessary worldwide. And there are, in different areas, different needs, right? So you have to be thinking about that as well. There are certain places where esophageal cancer is very predominant. And so you need to be aware of that so that you can create the right systems to take care of those patients. But we have to think about global as inclusive of all types of conditions and problems, and not just infectious causes, not just public health causes, but really also surgical conditions as a part of that. Okay, so the story of surgery as a part of that global framework has existed for a long time in various ways. But one of the more, in the last sort of 20 years, there's been a lot more thought given to how do we think about surgery in that global context. And Tom Weiser, who runs the global surgery program at Stanford, wrote this paper back in 2008. And this is my summary of his paper. This is not a graphic from his paper, although it could very well have been included at that time, which is largely that the population size and surgical need worldwide is in low-income countries, but that the surgical volume is in high and middle-income countries. And so there is a significant gap between where people live who need surgical care and where surgical care is delivered. And so then how do you make those needs match? Obviously, if you look at this, you can also imagine where the resources are and where they are not. And so that's an important concept to think about. Around this time is when there were some important editorials written by Paul Farmer and Jim Kim, saying that surgery is actually the neglected stepchild of public health. The surgical burden of disease was actually a really important component of public health. And that was the first time that people actually started to say, well, how do we know that? How do we measure that? How do we count that? You'll see numbers saying, oh, the percent of blah, 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 X disease is whatever, in whatever country or around the world. And that attempt, there's been attempts, by the way, since 1993 to quantify disease burden around the world, all diseases, all countries, okay? Initially part of the WHO, and then moving on to what is now the Institute of Health Metrics and Evaluation at the University of Washington, bankrolled by Gates et al. To, on an annual basis, systematically count and understand every disease in every country. All right, just think about that, 196 countries, 8 billion people, what an effort that is. But with the goal of trying to say, well, where should dollars be spent? Where should educational efforts be put in? And surgery wasn't initially ever a part of that. And there was this movement to say, well, maybe we should start counting. And there was initially an estimate by a professor, now retired, Haile DeBas, who used to at that time be the chair of surgery at UCSF, who said, okay, well, what if we estimated the burden of surgery worldwide? What if we just asked surgeons around the world to say what component of their care is surgery related? And they did that. They did a Delphi survey and found that it was 10% of diseases had surgical needs. And that 10% in the global public health world, they're like, what? That is absolutely insane. That's a huge number. We expected it to be a tiny little fraction. Surgeons are not necessary. Okay, that was the previous paradigm. Moved on to actually then try to do a systematic assessment. Let's see. In 2015, so there was momentum 2008 to 2015 to say, that's a large number. And can we actually get more information? And so the Lancet actually commissioned an entire issue, all articles entirely on surgery, to say, can we figure out what is the burden of disease? What is the cost of disease? What is the cost of not providing care? Right? Makes sense. And essentially found that one, the majority of the world didn't have good access to surgical care. This is the first systematic attempt to quantify surgical care and need worldwide, right? And two, is unaffordable for most people, put a lot of people into impoverishing expenditure. And basically that was a huge burden. And actually they found that 5 billion didn't have access. And these are estimates, right? Because you can't actually count this. Millions of procedures that were needed that couldn't be done. Millions facing catastrophic health expenditure. And this group then advocated at the World Health Assembly to say, you know what, we really need to think about surgical care as a part of healthcare across all countries. And so that was an important step to say, here is what we in surgery, in the surgical community, are thinking about, and making that argument to the non-surgeons. And especially the non-surgeons that hold the purse strings and that have funding, to say, here's how we're allocating dollars. So the ministers of health to say, well, if surgery is a huge component of what your population needs, what are you dedicating to that population? There's also in this paper, when they actually counted, it's roughly 30% of the burden of disease actually was related to surgical needs. So not the 10% that was considered astronomically high, it was actually 30%. And there was a very small fraction of surgical care that was occurring in low and middle income countries. When you think about surgical care, we think about a variety of things. Think about trauma, which is a big thing. If certainly for the folks on this side of the room, if you've traveled outside of the US, I mean, my family's originally from India, it scares me to cross the road because it's just congested. It's just terrifying. People are driving in every kind of way. It's scary. And by the way, the majority, I'll say about 70% of the global burden of surgical disease relates to trauma. And for the plastic surgeons, you all fix all kinds of trauma-related consequences all the time for all parts of the body to be able to get back to functional status. Cancer, obviously, is a big thing anywhere in the world. Congenital problems, less so in the US, and you all who are learning in this environment, the demographics you're exposed to are older and older adults. You're seeing less and less pediatric and younger patients and their problems, which our colleagues in the rest of the world are see a lot more of that. So congenital conditions are an important component of global surgical need. Acute conditions everywhere, whether it's appendicitis or infections or burns, and increasingly non-surgical things, like think about kidney transplant. So I had a meeting with our head of transplant here last year. So what's your interest in global engagements? And she said, absolutely, it's critical. Why? Because if you don't think about global systems and you don't think about setting up transplant where it is needed, then you incentivize other, perhaps less savory things like human trafficking, organ trafficking, things that we don't necessarily think about. Come down to, are there systems that allow appropriate delivery of healthcare where there's a need for that healthcare, right? And so those are all really important. Obviously, pregnancy and peripartum complications are surgical complications, right? 100 years ago, there were just physicians who did surgery and who did laparotomies and C-sections and took care of pneumonia and gave vaccines, right? And we've developed these specialties over time, but we shouldn't divorce the idea of delivering surgical care around pregnancy from surgery care worldwide. That's an important part of it as well. By the way, that Lancet Commission paper estimated that if there was not a mechanism to enhance surgical systems worldwide, that in a 15-year period, there'd be roughly about $12 trillion in losses. As part of their attempt, again, this was the first time anybody has ever estimated what the burden of the disease is and what the burden of the cost of not delivering that care is. And that, by the way, is like the GDP of China, like not a small country. So an enormous amount of need and potential loss, right? So let's talk about surgery and surgical care again. But surgeons, many of us went into this field just like most doctors went into the field, is to be able to take care of people. And we've had a long-standing engagement with all kinds of NGOs to try to do what we can to make the world a better place, right? All these wonderful groups that many of you may have heard of. The perspective here, I'm going to talk about the perspective of the American surgeon, right? So many of my colleagues have gotten involved in mission-based surgery as a part of how they contributed not just to their local community, but to the worldwide community. But as we started to quantify in the last couple of decades what surgical volume looks like, yes, please come on in. Please come on in and have some lunch. As we've started to quantify what the volume of surgical care is, speaking from that American perspective, you know that going somewhere for a week and doing cleft lip surgery is not going to be able to do it, right? It's obvious. It's obvious that model will not work, right? So there's a role for that humanitarian surgical perspective because surgery is all about service, but we also need to think differently. And we need to think not just about sending an American surgeon somewhere, because that, one, is not going to be sustainable, and two, doesn't value the expertise of the folks who are in all these different places. They're not just their technical expertise, but their context expertise. And the reason that's useful to think about it this way. Think about any of you coming to visit me in my home and saying, well, actually, I think you should put your couch there and your kitchen is organized all wrong. And why do you have eggs and not butter in your refrigerator? Well, I'd throw you out of my house, right? Naturally, because you have no idea what I need and why I have things where I have them. So what is the expertise that is there that is context-based? What is the expertise that is there content-based? So if you think about a surgeon from India, for example, population 1.2 billion, right? A country that has fewer surgeons, clinicians than the US, right? Just by ratio. So I'm a trauma surgeon by training. So a trauma surgeon in India is probably seeing like 4 times the volume I see, right? So their expertise is real compared to my expertise, even though I'm at a fancy level 1 trauma center and I've been trained in all kinds of fancy places. So what is that content expertise that exists around the world? So we can't think about this model of somebody owning all of the expertise here and then somehow delivering it to the rest of the world, because that doesn't work. We can't think about it that way. We have to think about it in a totally different way. We're going to think about it in a way that says, okay, well, how do we think about surgical systems in various places? How do we think about all of these different aspects that are needed for surgical care? How do we advocate for surgical systems to be developed? How do we collect that surgical capacity and information? Where do we train the next surgeon or create the next specialty based on need? And how do we work across all of these different disciplines? And so this concept of a surgical ecosystem was, surprise, surprise, created by my colleagues, Dr. Price and Dr. DeVries here at the University of Utah, who helped found the center 12, 13, 14 years ago. And that's one of our main surgical textbooks, Schwartz's Principles of Surgery. And this is from a few years ago where they kind of first said, you know, we as surgeons need to think about surgical care differently, not just in the US, but everywhere, but also in the US. We don't learn how to think like this either. So we need to think about this. And we need to think about this if, let's say, you're working in a small community hospital in Idaho or in the Indian Health Service. You need to be thinking about these same principles. So really, the paradigm has changed over the course of the last 10, 20 years to say, how can we think about improving and increasing surgical capacity in various parts of the world, including the US, including parts within the US where surgical care is not adequate. By the way, the Indian Health Service, which many of our colleagues may not know much about, is the health service for our indigenous population. It's chronically underfunded, and those populations have worse surgical outcomes for every surgical condition compared to the average American population. Okay, cancer, trauma, you name it. So it's important for us to learn these things, both domestically and globally, right? And then to think about education and partnerships, think about how do we create those systems? What is the evidence that we should base our recommendations on, or what is the evidence that we should base care on? And how do we solve some of these problems through innovation? Kind of overwhelming if you think about it. But that's part of what we as a center have tried to do, try to create partnerships in various places to say, how do we think about this in a more holistic manner and not just about going and doing an operation somewhere, okay? This is most of our faculty who are engaged in from the University of Utah, from the Center for Global Surgery. And Dr. Edward and Dr. Grace are our site directors in Ghana for the West African region. We don't yet have site directors for any of our other partnerships yet, because we're still trying to figure out how we should be structured. This is what our center is working on, is envisioning a world where safe, effective, and affordable surgical care is accessible to everyone. And our center and some of my more senior colleagues have been involved in really advocating for that role for surgery at high levels, at the World Health Assembly, passing this resolution 6815 and 2 others subsequently in the last 15 years that have advocated for surgical care, perioperative care, anesthesia care, emergency care, all of those things. And and writing papers, helping stand up a variety of different societies and organizations, and even making recommendations to Congress to say, hey, for that PEPFAR funding, can you create something for neglected surgical conditions, not just for infectious causes? So there's been a lot of advocacy that have been happening, and surgeons have to do that, right? You can't say, hey, ID doc, can you advocate for us too, right? That doesn't work that way. And so you need to be involved in that. And so that's what we've been. Oh, I didn't update this. This is as of last year. And every year there are numerous subcommittees that were been involved in advocating to say, can we incorporate dedicated funding for surgical care globally into our budget within Congress. So that's a overview of how we've been thinking about it. The Center for Global Surgery is a partnership between surgery and OB-GYN. Although largely has grown out of the Department of Surgery. Our engagements are in these countries and country partners at the moment. A lot of it driven by specific faculty, and I'll tell you a little bit more about each of the different collaborations. Many of our faculty across different specialties within surgery are engaged in a variety of different places. Focused on education, focused on research, some combination, as well as innovation. I'll tell you a little, very briefly. Both folks on this slide are here. Professor Pius, who just walked in, thank you for being here, and Dr. Rockwell. I'm going to just give you a snapshot of a number of different collaborations that our faculty are involved in. So these guests are here as a part of this plastic surgery collaboration, which has led to one of the first hand surgery fellowships outside of the US. It's been approved, is that the right word? Accredited, maybe.
Society for Surgery of the Hand.
Yeah, worldwide, right? And so ensuring standardized training, ensuring standardized skills and high quality skill delivery, and a sustainable model of practice to be able to ensure that patients are able to get the care that they need, right? So that's an amazing, amazing partnership. Dr. Price has been involved in Mongolia for probably now going on 20 years almost. Mongolia, he got engaged there in Mongolia. Yes, please come on in and grab some lunch. And Mongolia is an Asian country that Dr. Price happened to visit many years ago. And pleasure to have you on, Dr. Sharma, at this hour, no less. It's in the middle of the night in India. And Dr. Price got involved in Mongolia, where he'd gone. And there's a lot of talk about trauma systems, but they actually were very interested in laparoscopic surgery. And the thought was, well, why laparoscopic surgery? But the focus should be on trauma, because there's the systems for trauma care are needed. But that was the local need. And it turns out that Mongolia, the weather in Mongolia is incredibly cold in the winter. It's like minus 30 degrees Celsius cold. Like really, really cold. And so they use a lot of yak's milk products, which increase the risk of gallstone formation. And so everybody has gallstones, and everybody and a lot of people have gallstones that have cholecystitis or biliary colic and need operations, and big open operations in a nomadic population are horrendous, because they can't take care of their animals and they can't take care of themselves or their families. And so there's a lot of need to say, hey, you know what, we would like to we have this clinical need. We need the right surgical skills to be able to take care of this population. So actually helped set up and expand laparoscopic operations for removing the gallbladder across the entire country over the course of the last 20 years. And that experience then has led to funding from the Church of the Latter-day Saints to implement laparoscopic training in Cambodia, as well as in Ghana, which I have not put up there, which is most recently, and as well as partnership in Ethiopia with the American College of Surgeons to, again, be able to increase the capacity to deliver laparoscopic surgery, which is minimally invasive, faster return to work, et cetera. Dr. Nunez, one of my trauma colleagues, has been involved in a bunch of different work, both in Mongolia and Ghana, but he and Dr. Jedu had looked at, well, great, we can think about surgical care delivery. We know that surgical care, we've talked about like how difficult it is to understand what the surgical need is, what the burden is, the value of quantifying it so that you can allocate resources, all those things. And over the course of the last, since the Lancet Commission papers, we've been trying to do that a country by country level to say, where is the data? How, even in the US, you can't actually get the data to say who delivers what care and where, what's the volume, what's the complications. You can't. We actually can't know the information that's in the Lancet Commission recommendations right now. But in a variety of places around the world, there's been attempts to try to do that. So Dr. Jedu and Dr. Nunez have worked together in the last few years with some funding from the Laerdal Foundation to try to quantify that across all of the facilities in the country of Ghana with the Ministry of Health. And I've actually in the process of drafting and presenting a lot of those recommendations now. And that's been really valuable work. This was a presentation that he gave at the World Federation of Surgery, of Societies of Anesthesia about 6 months ago, about some of the initial preliminary results. And there have not been many successful projects like this. There have been many attempts, but successful is a whole different story. Urology, the group in urology has been incredibly active. Dr. DeVries, who's the founding director of our Center for Global Surgery, also had set up in 1995 an organization called IVU Med, International Volunteers in Urology, Teach One and Reach Many. And she really kind of was a proponent of this idea of how do we build capacity? How do we teach? How do we enable colleagues to learn these different skills in different places that would then advance their ability to deliver care? And Dr. DeVries is our division chief of urology, and Dr. Jane Kurtzman is one of our senior fellows in reconstructive urology, and they've set up a new program now called U Impacts, which is specifically in Rwanda and in Cambodia with the urology societies to say, how do we build urology services? How do we conduct urologic training? How do we develop specialty expertise within urology? So pediatric urology, cancer urology, reconstructive urology, because those are all needs that exist, but you can't just send like one surgeon somewhere to go learn that. How do you then create the systems to be able to deliver that? Dr. Huang is one of our colorectal surgeons. He and Dr. Kwache and Dr. Laria are other colorectal surgeons from other institutions, have been involved with the Ghanaian College of Surgeons and Physicians and Surgeons to help stand up the first colorectal surgery fellowship there in the country. And Dr. Agbadinu was here a few months ago and actually gave a talk in this room. And we've just recently, in the last week, Dr. Agbadinu and Dr. Huang have gotten a grant from us to start looking at. So if Dr. Agbadinu is the first colorectal trained fellow in the country, that's a lot of weight on his shoulders to say, how do you even think about colorectal needs? What are the first things you would ask? What are the things you would set up? So how do we think about that? And so that's what they're working on, are going to be working on over the course of the next 2 years with that funding. Dr. Brownson is one of our breast cancer surgeons. She and Dr. Tuttle from Minnesota and a number of other faculty have been involved in breast cancer care in Mongolia and Ghana. And she has funding for a collaboration in Ghana with Dr. Josephine, who's a breast cancer surgeon there as well, to think about breast cancer care and women's health and what are the systems that are needed to be able to deliver not just surgical care, but also medical oncology and radiation oncology. And what does access look like? So a variety of different collaborations there. More recently, Dr. Foster, who's head of the University Teaching Hospital in Kigali, and Dr. Brook, our division chief of vascular surgery, have connected on thinking about how do you incorporate vascular surgery training into the general surgery residency in Rwanda, and how do you build a standalone vascular surgery fellowship. And so we're in the process of trying to create that curriculum in collaboration with some of our UCSF colleagues who have successfully created that kind of a training model in Tanzania, and they've been kind to share some of their resources. So this is one of the things that's ongoing now, and I'll just touch on the OB-GYN part, and I want to speak on behalf of my colleagues from this other department, but they've set up a Women's Health Equity Fellowship, and part of their rural, global, and underserved women's health program, where a trained OB-GYN who's finished their residency then spends a year domestically in the Indian Health Service, and then a year with colleagues in Rwanda at the University Teaching Hospital, and where they're working on setting up a gynecologic fellowship. And these two gentlemen, Dr. Theodemir and Dr. Adolphe, are two OBs who've spent a good portion of the last 2 years here as a twin fellow with Dr. Euclidito, and I have not included our other fellow on there. So there, and these are partnerships that are ongoing to think about OB care. So we have lots of links to a variety of different departments, and there are a lot of different experts both here and in the various partnerships that we have. I'll tell you just a very brief bit about what I personally do. So as I mentioned, I'm a trauma surgeon. I'll tell you about this particular collaboration I'm part of with the Ministry of Health of Rwanda and the Rwanda Biomedical Center, and a couple of other institutions. So as I mentioned, trauma is my specialty. And as it turns out, if you count the numbers, about half of the deaths worldwide are related to emergency conditions. And the largest share of that is trauma or injury. And worldwide, the high-income countries only have about 10% of the volume of trauma. It's where all the major level 1 trauma centers are, and all of the fellowship trained blah, 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 and all the ICUs and all the resources. Same thing for pediatric trauma. The majority of pediatric trauma does not happen in high-income countries, which is where all the resources are, all the pediatric hospitals, children's facilities. And there's a huge burden both in terms of death and in terms of disability. And we have no idea what the mental health impact is. Not quantified, not studied. Nobody's dared to scratch that itch. By the way, in the US, every level 1 trauma center, which is our highest tier trauma center, is mandated to have a psychologist and have an assessment of the mental health impact for all of our trauma patients for the 10% of the volume of the world, right? So it's important for us to recognize one, what the standards are and who sets the standards and who has access to the resources to meet those standards. As I mentioned, my partnership with colleagues at the University Teaching Hospital and Ministry of Health, it's been longstanding, almost 15 years now. Started out looking at trauma epidemiology, and it started out when I was a fellow at Harvard at the Brigham and Women's Hospital there. As a trauma surgeon, I depend on a system to exist. Patients have to come to me after a car crash. I'm in the hospital. I don't go out to find patients. They have to get to me. And that means there has to be a system. And that means there has to be, especially an emergency medical system, where somebody is able to recognize that there's a problem, call the right resource. The right resource has to show up with the right ambulance and the supply chain and the medications and the trained staff. And they have to get to, which is difficult, the patient, because in many parts of the world, and even in rural parts of the US, addresses are optional, because that's just how it is. Right? If you go out to a ranch in the middle of Idaho, there isn't an address, right? So like you just have to think about how do you get somebody from that, how do you get to that location, and then how do you get them to the right facility somewhere else? Which facility is right? What do they need? What do they have? What is available that day? Are all questions that have to go into the mix for the person to end up where they need to be and to get the right care. So this is the process in Kigali where we've been working on EMS related capacity for a long time. One of the assessments we did basically said that they have a fantastic division of EMS. It's part of their public health system. It's funded by the Ministry of Health. They have ambulances, they have trained staff, they have supply chain. But and they have a 912 phone number, which if you call, they'll be able to send an ambulance. But they still have trouble locating that patient. They still have trouble figuring out which hospital to take that patient to. And all these red arrows are all different phone calls that to make to figure out how to get there and how to stabilize that patient and get to the right hospital. So we've been working on an electronic system that is locally developed by local software developers, building that local capacity again, to then connect the ambulances and the dispatch center and the hospitals so that the system can be more efficient. So that the patients can be located, and especially these days with GPS data, we can locate people much faster. And we can also then interact with the hospitals. And one phase of the project that is yet to come is to interface with the hospitals to have real-time understanding of what does the hospital have? Is their CT scanner functioning today? And do they have an available ventilator to then be able to decide where the patient should go? And that system, by the way, when we presented it at a conference in Canada, they said, could we have that? Because we need that too. We don't have that. So those kinds of systems are really important everywhere. But we're learning and working on that in Kigali specifically at the moment. So for the last 2 years, we've worked on developing the software, testing it, ensuring that the staff find it acceptable. These are some of the leads of, Eugenie is the lead of the nurses for the EMS system. Philommene's the head of the dispatch team. And that's Respicious, who's the one of the software developing staff, working together on both a mobile and a web-based interface. And we have since implemented that. It's now in use for the majority of the patients receiving EMS care in Kigali. It's the standard. We're still working on a variety of things. We're doing things like assessing the times and whether they're within target or not, figuring out how to display that information, who at the Ministry of Health wants what information, thinking through what you would benchmark against, how you would use this information to then look at delays, work with the head of police to say where are we going to put police officers so you have fewer delays, et cetera. So really looking at it in a systematic way. So that's just an example of what I'm working on as a part of my time. So I'll go back to the center and go back to thinking about education. So none of what I've said is probably magical today, right? This whole concept of like surgery as a part of health is not rocket science. But it is something that we need to be thinking about and learning about in a specific way. At the center, we've tried to have formal ways of learning that. So we have a monthly lecture series. That's what today is. We try to have lunch. We have a couple of sessions. So these are all every Wednesday. And we try to have works in progress twice a month. One is specific to some of our Ethiopian projects. The other is for any of the projects that anybody's involved in. Anybody can present and kind of give updates and say, here's what I'm struggling with. Here's what I need advice on. What are, and then the group kind of discusses. There are also multiple courses that are available at the School of Medicine. This is for the students in particular, so these are all electives. There's one specifically that's on surgery and public health. These other 3 courses involve surgeons as a part of global health. So they're all available to you. One of the many things we've had to do in the last few years is say, well, if this is a specific field, academic global surgery, how do you learn it? What is it? It's like if you take calculus in Malaysia or India or Idaho, it's the same thing, right? You know what the fundamentals of calculus is. You know what the fundamentals of plastic surgery in various parts of the world. Well, what does it mean to study and learn what we've been talking about? Well, what, is Dr. Rockwell automatically a global surgeon? Is Professor Pius automatically a global surgeon? Or is there a specific expertise that comes or that has to be learned or acquired? And how do you teach that? So that's been an effort that we've spent a number of years to try to understand. And so we've actually developed a universal set of competencies in academic surgery, academic global surgery, and we've developed an online course that is available worldwide and that we're updating based on these competencies to say, here's what people should be learning, no matter where they are in the world, about this topic. And here is what you should know, whether you're a student or you might be a practicing surgeon, you just want to know more about it. Here's how you should think about it. Here are the things you need to know. Here's what it means to be an expert in this. And then within our group here, within our institution, we've created various pathways, both to kind of teach those competencies and to give students and trainees a chance to actually apply those competencies towards a particular project and work on various, work and present at our various meetings. And learn from all the different collaborations. So if you're interested in plastic surgery, this might be a good time to connect with this collaboration to say, hey, what are you interested in and what can I get involved with, right? And then what we would say is, then we'd have you do this online course as sort of an understanding of what we talked about, but in a little bit more depth. And it's on your own, it's asynchronous, and then you work on creating a project, and then we'll work on advancing what that looks like. What is it that you need? What kind of project is that? Is it an educational project? Is it an innovation thing? It may be that there are multiple colleagues here thinking, well, actually now that I've been here, now that I've seen a different system, I think we need to do X in my system. How do we develop that? How do we implement that? So those are all different things. Newly this year, we've set up a multi-departmental global health research grand rounds here at the University of Utah. Again, once a month, in person with food. Last week, Dr. Nunez, one of my partners, talked about surgical indicators as the inaugural speaker. Next month, Drs. Watt, Kamani, and Suneja from oncology will be talking about stigma research. And lastly, we've created a Master's of Science in Clinical Investigation track in Global Health Innovation. We have classes, run a few classes. This track is available for anybody who's interested. One of the students who participated in that track, for example, is now a neurosurgery resident in the country of Colombia, and she helped develop a low-cost cranioplasty device that she's submitted to the U.S. Patent Office as a part of this program. And this is, we're one of several collaborators, but we lead that training. And that's pretty much it. And I've told you about our faculty, the people who do the work and standing up all these things are Liz and Anna, who are up front, and then Hafsa, who I think might be online. And that is all I have to say. Questions, thoughts, comments, complaints?
Thank you very much. Could you give a little more detail about the online program? You said that would be appropriate for some of our visitors.
Yeah, it's something. So we currently have it's a 20-hour online course on Canvas. It's very specifically to learn about the different principles within global surgery. We're in the process of updating it to add more videos and lectures and things, especially from some of our collaborations. But it is to specifically talk about the different competencies within global surgery, and it will be open to anybody. And we're making it a certificate. We'll be making a certificate for it, and then we're also making it hopefully an elective at the medical school and the undergraduate campus, so that. And it'll be available for free for the non-Utah folks. The University of Utah will yell at me if I make it for free for the University of Utah. But it'll be non-credit if you want to take it for now until we make it credited. So, all right.
Okay.
Yes.
Yeah, thank you so much for the presentation. And obviously, I wouldn't have even known that the surgical burden for the world is up to 10%. Yeah.
So now 30.
So it's not that.
It's 30.
So now, when we have issues like this, it's difficult. It's a big thing you're doing, you know, and I see it in few years. If you have the right people, to be part of the whole thing, you know, like what you do, generally, you know, if you use what we call the pestle analysis, political, there's no drive for health without political involvement. You're just going to push and you get tired.
Yeah.
So sometimes the politician that you don't like are the main driver.
Yeah.
Now, there's also economic, which is the money, the funding. Otherwise, you also gas out. You need money. So we can look at other things like the social parts, which is the cultural people, the place you are taking it to. Will they accept it? Are they willing? Because sometimes you might even want to do something and they're saying, no, we don't want it. You know, you're trying to take something from us. That's why you're offering this free health.
COVID vaccines in the United States is a great example of that.
So,
or vaccines during COVID.
It's pretty big. And I think now that it's still in the, I would say the nursery stage, if there's something even lower, that things like this should also involve WHO, political.
Yeah.
So,
yeah, exactly.
Because you can imagine if WHO decide to take it up and say, okay, let's design a protocol that we share with all the world leaders, the same way they are talking about climate change. Everybody's talking about it's political. And, you know, getting funds from everywhere, you know, 10%, 2% from different parts of the world. I think that's the way to look at it.
Yeah.
The other question I wanted to ask is, how do you decide where to go next?
So, great comments. Thank you for those. And so there is an organization that I didn't touch on it called Global Surgery Foundation, which is trying to function a little bit like the Global Fund for TB, HIV, and AIDS, Global Fund, but for surgery. And so to try to then pull in the donors to then be able to support surgical systems with a really large ticket. So there is some work being done in the political and economic space at those levels. And some of my other colleagues have been involved in helping push for some of those changes. In terms of at the University of Utah, how do we enable and create partnerships? The center itself doesn't create any partnerships. The partnerships are based on faculty, typically, saying, where is their interest? Where is their need? Where does it make sense? Dr. Rockwell can't show up in India and say, hey, I would like to implement this here, right? But if he has a specific partner, like Professor Pius has been for many years, then the collaboration is, oh, great, you know, let's work on a hand fellowship, oh, and then a burn fellowship, and then a breast cancer fellowship, and that builds more horizontally. And so it really is not a which country do we partner with, but where are there opportunities from the University of Utah? And maybe it's not always the University of Utah. Maybe it's people in other groups that we interact with, like UCSF, for example, has partnerships in Cameroon. So if there was a Cameroonian surgeon here, you know, I would want to definitely connect them with the UCSF folks, not because we don't want a collaboration in Cameroon, but build capacity where there's already partnerships. And so that's how we think about partnerships in the United States.
Looking at developing a scoring system where you look at where there's more body in specific parts of the world, then you basically target those areas where you have. So you can design a scoring system, so you can score it and say, okay, this is 100 here. So because if you're doing colorectal and you realize another country need 1,000 people, or so you can design a scoring system that can be used globally. So
I think that's a great project to work on and to kind of say, well, how do we say where should we put the next set of resources, right? But who determines that? Which surgical group determines that? Or is it a surgical group at all? In fact, some of the work has been done historically by a group of health economists. So there's a publication called DCP, Disease Control Priorities Project. It's now the 3rd edition, came out a few years ago, where they've tried to quantify that from an economic impact. And what the economic impact of, so for example, at a district hospital, what is the economic impact of doing cataract surgery or a cesarean section or fixing a broken femur? And what is most cost effective? And so there have been attempts by non-surgeons, with some surgeons involved, to try to quantify where those resources should go. And those are important questions to ask. And there's not any one group that can ask those kinds of questions on a global scale. You can ask that for your city, your country, your population you're familiar with, where you have access to that kind of data. But yeah, I think those are great. And that's exactly how surgeons need to be thinking, right? This is very different for surgeons. Most surgeons aren't thinking in this way. We're thinking like, what is the operation? Can I get technically better to deliver a better operation? What technical skills can I acquire? But this is a different, in some ways, kind of almost an uncomfortable way, because we're not used to thinking about these kinds of things. But that's where our growth is. And that's also been historically where there's been challenges in suggesting to surgeons that global engagement is in this manner is actually appropriate and encouraged, and all of those things. Because the surgical community is like, why should I be involved in asking those questions or answering those questions?
Well, I think the world is becoming more global. And so if you feel that if you feel that your trouble is just your trouble,
yeah,
tomorrow they'll bring the other people's trouble, because we don't solve it all. Yeah, it's becoming everybody, we all need to work together.
Yeah, we have to.
We are far
Yeah,
apart,
you have
but
to.
we realize that the burden of one country is actually going to affect the next country.
Yeah.
So, so we should all think differently.
Yeah. And with that, it's 1 o'clock. Thank you, everybody online who are still remaining. And I don't know if there are any questions on online. Okay. Yes, question in the back.
Very lucky. Actually, been very filled by global surgery residency.
Yeah. Mm-hmm.
Because participants of the public health
Mm-hmm. Mm-hmm. Mm-hmm.
so very sadly that the WHO has not recognized
Yeah. Yeah.
the public health
Yeah.
problem,
Yeah.
even though they recognize some other non-communicating diseases. I think burn is also
Yes. Yes, absolutely. And actually, if you look at the global surgical literature and the trauma literature, there's very little written about burns at all. And if you look at SDGs, there's some discussion about trauma care. But there's, in fact, SDG 3.6 is about trauma care. Interestingly, slowly that metric kind of gets ignored. Nothing about burns. And burns, especially for pediatrics, for children and for women, are a big issue, and it's just not even discussed. So and our burn surgeons, by the way, are very interested in being a part of collaborations, and they've been discussing. I think they've met with Dr. Rockwell. They certainly have. I and Dr. Foston, who's from the University Teaching Hospital of Rwanda and heads the burn unit there, have had meetings. So there have been a lot of attempts from our specific burn group to try to engage with colleagues around the world. And if you're interested in connecting with some of them, especially while you're here, that might be a good thing to do. Yes, Dr. Mamadou.
Robot surgery included the languages. Because in
Yes.
we have many
Yes.
countries, we have different languages.
Yes. Yeah.
Spanish,
Yeah.
French,
Yeah.
and you.
That's a fantastic point, right? as is very common, so many things happen in the English language and don't happen. So, for example, if you go to talk to the global, like you go to the American College of Surgeons and the global surgery group, so much of it is actually even focused on the African continent. I'm like, well, what about the rest of the world? What about the Latin American continent? And what about South America or East Asia? And so that's a really important blind spot that we English speakers have and need to recognize. So many times, many of our conferences do include real-time interpretation, translation for French and Spanish, for example. That's been a part of some of the international conferences, especially in the last 4 or 5 years through Zoom. And there's been increasing efforts to write and translate some of the publications and publish both in English and in French publications, so that you have accessibility to address that. But language is a huge opportunity.
Some of the updates you do for our future academic course too, on top of that, and our doctorism talk stuff is translating from English to French and Spanish. Wish we could do more, but there's a bajillion languages out there, you know? So we're at least trying to hit the major ones.
Yeah. And it's important to ask these questions, and thank you for pointing that out, because that's exactly the kind of prompt we need to make. And sometimes you don't know until somebody asks. Okay, with that, I think I shall conclude. Thank you, everybody, for being here, and yeah, I appreciate it.